All right, welcome everybody. I'm here to do kind of shit that happens. You got us kind of. So
So one
thankfully, the
one
AI,
qu-
yeah,
one quick question before we go. So what's your policy on cussing here?
that's free and open. I mean, literally call the JAFERD cast, just another fucking ER doctor. Welcome everyone to this episode of the JAFERD cast. I am your host, Dr. Mark Papadakis. Nobody particularly special, just another fucking ER doctor. This week, I have Dr. Kenneth Swanson on here with me, infectious disease specialist and one of my former classmates as well. We're going to be talking about measles, vaccines, and in general, tips about how to be a better doctor for those of you physicians and even nursing who are listening to this episode as well. So, without further ado, let's get him in here. All right, I'm here with our guest for this week, Dr. Kenneth Swanson. Kenny, how are you doing?
I'm great. How are you, Mark?
I'm doing fantastic. Thanks for being on the show. I really appreciate it.
Oh, absolutely. It's my pleasure.
So, Kenny, tell us a little bit about yourself. Obviously, at this point, you're my colleague. We and I went to medical school together, but tell us a little bit more. Were you trained? Where you're currently working? Things like that.
So my background is a little bit all over the place, and I think that actually makes life a little bit more fun. So I'm originally from the suburbs of Chicago. I went to college at Michigan State University, where I got a bachelor's of science in zoology with a concentration in animal behavior and
Really?
neurobiology.
I did
Yeah,
not know that. That's news for me. That's pretty cool.
we're learning new things. So, the classification of organisms, both beneficial, symbiotic, and detrimental to us, is really been part of my background for a long time. And as you know, I went to medical school at Toro College of Osteopathic Medicine, and a place that really broadened my cultural background and understanding of the world, Harlem, New York, and also
Right in the heart
expanded
of
my.
Harlem, 125th Street, man. Right there, across from the Apollo, everything.
Absolutely. It also really broadened my food palette too. There's so many great things to eat there too, which was always a lot of fun. And then I went on to do my residency in Park Ridge, Illinois, outside of Chicago at Advocate Lutheran General Hospital. And I moved to Milwaukee to pursue my fellowship in infectious disease at the Medical College of Wisconsin. And then
So your residency was in what? What did you actually do your residency training in first?
internal medicine.
Okay. So internal medicine followed by infectious disease fellowship. And how long was that fellowship for?
Mine was 2 years. The fellowships for infectious disease can really vary widely. Normally, it's 2 years. If you do an extra research year, then it becomes 3 years. And then there are some places, some universities, you can go as long as 4, 5, 6 years if you really want to do a lot of research. And then I went on to take my attending position at Aurora St. Luke's Medical Center in Milwaukee, which is the flagship hospital for the system in the state and is now actually merged with Advocate. So it's all through northern Illinois, most of Wisconsin, and they've even merged
Wow.
with another group in the American Southeast, Atrium Health. So it's a pretty large system.
And you guys get, obviously, if you're at we call the mothership, right? So you're at the main big hospital. You have a lot of satellite little hospitals, but then you guys get, I'm sure, transfers from your outlying hospitals all the time. And those cases, infectious disease, you must see a lot of stuff.
We do. We are the main referral hospital for the state for the Aurora system, and we even get some from the Upper Peninsula of Michigan. There are a few large systems within the state of Wisconsin. There's also Fredericton Medical College, and then there's also University of Wisconsin system too. So I'd say there are three major hospitals in the state, all within a couple hours drive of each other. Then that leaves the whole rest of the state to refer down here. Unless you're in northern Wisconsin, then you can come here, but sometimes you end up going up to Mayo and Minnesota, which is close by.
So there's a lot of talk about healthcare deserts, especially in the U.S. Now, you're all the way in Wisconsin. We're talking about Illinois. Obviously, Wisconsin isn't not necessarily rural America, but there are definitely parts of the state that farmland and there's really, general lack of civilization outside of your small towns. Do you find that the people coming to you from these outlying hospitals have not received a lot of medical care, medical attention, or are they perfectly well taken care of in their own community and they just get complications that they can't handle?
And that's an interesting question. And that really does vary, as you would expect anywhere. Now, what you'll notice in a lot of the major metropolitan centers in this country, especially on the American East Coast, what you're used to, is there does tend to be a little bit more of a gradual transition to urban to rural, right? You're going to get the big city, then you'll get the suburbs, then you'll get the exurbs, and you'll get the farmland. That's a little bit more of a rapid transition in the state of Wisconsin, whether you're in Madison or Milwaukee or in some of the other places. You make that transition very, very quickly. If you want to drive from the heart of Milwaukee into straight up farmland, it's not that long of a drive. If there's no traffic on the highway, whether you're going west on 94 or north on Highway 43, oh gosh, on a normal day, 25 minutes at the
Oh.
most. It's not a
Mhm.
far drive, but again, it depends what you're going towards. I'm sure you'll have people who listen to this from here that might say, "Well, no, if you're driving this specific direction, it'll take you 35 minutes." But generally speaking, no, you can make that transition quickly. But then there are places in the state where I would definitely consider the availability of care a little bit difficult, and that especially is true within VA. When I was in fellowship, I was in the VA, and there are a lot of places where telehealth was really the main thing, where people would have to transfer in. Although the VA footprint has expanded, I don't know what's going to happen now with the funding issues. But for
Yeah, I was gonna
me,
say now there's a push between not even just the overall federal government. I mean, Medicare, Medicaid have been paying less for telehealth over the course of the last 5 years, let alone the funding discussions occurring right now.
yeah, and before segueing into that, I'll answer your previous question. Some of the systems here have done a really good job setting up hospitals and clinics in areas that would otherwise be pretty underserved within the state of Wisconsin. But I do find that the healthcare literacy could be better in a lot of the rural and middle of urban areas. Whereas in some cities, you'll find that disparities in healthcare literacy among patients is very clearly different in rural areas as they are in the city. Whereas here, I find healthcare literacy could be better across the board. I really do feel that way. And you're seeing a lot of the same healthcare concerns in patients who live out in the dairies or out in these places in the rural areas as I do see in the middle of the city. You're seeing a lot of the diabetes, you're seeing a lot of the obesity. I've actually joked that there should be an epic dot phrase for the Wisconsin patient: diabetes, hypertension, obesity. You know what I mean? It's the truth. And that's not a judgment on the patients. That's just, I think, unfortunately, an education problem in general.
Yeah, and it's indicative of healthcare in America right now too, which is a lack of reliable education. I've said this before in other episodes. A lack of reliable education. It's a lack of too much information sometimes at a fingertips, and a lack of the ability to parse through that at a reasonable rate to figure out which is reliable, which is not, which is anecdotal, which is more evidence based, and it's also a difficulty with doctors and healthcare people in general getting to those parts of the country to educate people and provide these care because at the end of the day, home remedies still exist just because they can't find a doctor, they can't afford a doctor or medication and things like that. It makes sense that you talk about how, the whole that area that you're serving right now, there should be an epic dot phrase. I've felt the same way. When I was training in Harlem, it was the same thing: diabetes, hypertension, obesity. We should also need a dot phrase. And it's a lack of diet, exercise, lifestyle. But a lot of these people have poor access to any of those things, which makes them more at risk. So it's not even just a discipline issue, it's an access issue too for these things.
And I would even take it a step further because when it's not only the information, it's not only the access, it's what do you do with it and why? Why should someone listen to someone telling them what to do? We come in, we see a patient. By the time we see them, sometimes they haven't seen a doctor, and it's not only access, it's why should I listen to this yuppie over here, right? Why should I listen to this person who has no common experience with me, right? They don't understand my life. They're not out there on the combine. They're not there out there milking the cow. They haven't gone to the school of hard knocks in the street like I can.
You're a city boy.
Right. And so I think part of it is people feel othered a lot by the healthcare system. Our establishing credibility begins when we walk in the door. They might assume that we have preconceived notions about who they are based on their background and what they look like. And they have that about us too. And honestly, why shouldn't they? I've heard a term that at first really made me angry called medical gaslighting of doctors, not listening to people or making them feel small or making them feel stupid. And at first I got mad about that. I go, we don't do that. And I think for part of it is we don't do that intentionally, is what I should say. I think it's very similar to another article I read about people in memory centers referring to older people with elder speak. Oh, hi, sweetie. Oh, hi. Can we go to the bathroom? I think, talk to people like they're human beings And when you're giving them advice on how to do it, share your own experience. There's this big taboo against that. I don't think we should shy away from that when it's relevant. I think we
Agree.
should be telling people, hey, here's why I think this will help you. It's your decision. The X, Y, and Z based off of your life and experience, which, hopefully they would have given you some information on that. And part of the way that I do that, I try to bridge that gap. The second I see a new patient in clinic is I say, look, I've read your chart. I spoke with Dr. So and so who sent you here, but I want to know, why do you think you're here in my clinic right now? What is you're in the infectious disease clinic. Why are you here? And
And that's something that I agree. And that's something I have to do better of as well, because oftentimes people present to the emergency department because their doctor sent them in and they don't have a good understanding of why they're there to begin with. That's not a small percentage either. That's a pretty decent percentage. And for me, it's frustrating because I'm emergency medicine. What do you mean you don't know why you're here? What's your emergency? And, at the end of the day, they're presenting to you because something is wrong, either because they realize something is wrong or somebody else told them, hey, something is wrong. Go there. And it's our job to parse through that. Somebody wakes up at 3 o'clock in the morning, 1 o'clock in the morning, they check their blood pressure, they come to the ER. Like, well, my blood pressure is high. Well, why were you checking your blood pressure at 1 o'clock, at 3 o'clock in the morning? Well, I woke up and I couldn't breathe. Okay, let's talk about that. So yeah, it's being able to sit with a patient and relate to them to some degree, to give them care that you are confident in is best, but now you have to in some way convince them this is the best thing for you. And here's why. And that's a challenge. And I think we talked, you and I personally, about this many times, how different generations see us differently, they react differently. So a generation that's much older than us was instilled to them that this is a doctor. You listen to them. You don't ask questions. You don't ask for clarification. You don't intervene with your own personal concerns. It's you go to the doctor, you listen to the doctor, you go home. And for now their children who, they come home and say, I saw the doctor. What did they say? Well, I don't know. What do you mean you don't know? Well, they said it'll get better. That's it. And then their children now calling us and calling up and saying, hey, what happened? What did you say here? Well, didn't you ask this? Didn't you ask that? So now there's a generational issue that we're seeing with older patients, especially in the ER where, older person comes in, I see them for X or Y, I send them home, and their kids are calling up and saying, what'd you do to them? They didn't tell me they didn't know what you did. It's like, well, I went over it with them. Yeah, I went over it with them, but they just kind of like looked at me, nodded, smiled, and said, okay, thank you very much, goodbye. And that's not right. That's not right.
And it's hard, given how the pressures we have for volume of patients, to take a beat and say, hey, repeat back to me what you heard in your words. And because sometimes we can do that, but sometimes time is pressing. But then it's important to do it, because sometimes when I'm busy and I don't do that, then it makes more work later when, as you're saying, the kids call back or they call back, right? And that's hard. And I think that that's a real issue that you've brought up. And that's a really good point.
The problem with our profession, in my opinion, is that it's kind of like Congress. It's being run by people, so many people over the age of 60 nowadays. Like the dinosaurs, the doctors who have retired but are still in power to some degree, who are still making the decisions in the big agencies and all that. And there's very little input with the younger generation too. The older generation, the baby boomers, obviously, and some of the Gen X, they respond to, well, I'm the doctor, here's what you do. And I say, okay. But the vast majority of people nowadays are not. That's not what they're doing. They have access to medical data that usually was only restricted to medical professionals, and they can't interpret the data. They know it's there. They can read it, but they can't interpret it. And now you have a wave of, well, I know what I'm going to do, what's best for me, what works for me. So therefore I'll take your opinion with a grain of salt, or I'll take it, in part, but I'm going to kind of go ahead and do what I do. Or they're going to shop. They're going to shop around for the person who they agree with and who agrees with them. And therefore, okay, you're now my doctor. You're the person I agree with. And we've clearly seen that leads to some shit.
I would actually take it a step further, because what I've found with people is to your point, there's the paternalistic nature of medicine where, it's, hi, I'm the doctor. I'm walking in my white coat. I have authority. Here's what I'm going to do. And when people respond to that, I actually haven't found it to be positive. I
Yeah.
stopped wearing a white coat in fellowship. I got a white coat when I started at my job almost 4 years ago. It hasn't left the plastic, frankly. And people have different opinions on that. Like, I have some partners that wear it, and some who don't. And what I have found, just for me personally, I can only speak from my opinion because I don't know what it's like to be someone who is a minority physician, right? Because what
Hmm.
happens sometimes
Yeah.
is people have their preconceived notions, and I'll just say I understand that people see a white guy, they're more likely to see me with the presence of authority, and that's wrong. Like that's messed up. But unfortunately, that's part of people's cultural gestalt here. That's what people see. But what I have found personally for me, again, I can't speak for anyone else. I don't know what it's like to be a woman in medicine because I know for several who have told me that unfortunately, if they're not wearing the white coat, people assume they're a nurse, which that's a whole
Yep.
separate discussion that I know needs
I've
attention.
had Yeah, I've
But
I've had colleagues who they wear the white coat and people still think they're a nurse. Like it's just,
it's
they
bad.
see a woman, they're like, "Oh, get the nurse."
I know, right? And I'm hoping that that's different. And I do practice in a city setting. So luckily, that's not as prevalent as it was in some places, or as it is in some places where people have a slightly different set of values. But for me, what I found is taking off my white coat. I find there's a little bit less space between me and the patient, and I kind of I feel out the situation, of course. But what a lot of people respond to, regardless of their generation, if I speak to them like a human being, not like a disease or a case, then they tend to respond better and they tend to take my advice more. If you let them know, hey, this is what I'm telling you. I'm not perfect, but based on my experience and the best available data right now on your current condition, this is what I recommend. Or I'll
Mhm.
say, hey, there's two equally good options here. Here are the risks and benefits of either one. You make the decision, and I'm here to support you and help you the best I can. And people do tend to respond to that and give their intelligence credit. If and you tailor the information and the delivery thereof based off of essentially where they're at. You meet them where they are. And when people start to go down the rabbit hole about things that are not well supported, even if it's a firmly held belief, I've told a couple of colleagues if a patient goes down the rabbit hole, jump in with them, meet them where they are, and then bring them back using language that they will understand. Or try to listen to their experience and then try to use their experience to help guide them in a direction that you feel is the safest option.
Do you find that your younger colleagues respond better to that advice than your older ones? Do you have older colleagues? Do you have younger colleagues? I don't even know
I
your
do.
group really.
And that's a really good question. And I have found that as anyone gets older, the ability to change your approach is difficult. But some of my older colleagues have been very, very agile with things. They've been able to respond. So my oldest colleague started our group, I believe, in the late 70s, and he's still going. He's in his 70s right now, and he's actually been able to pivot really well on things. We have a nice wide variety of ages in our group. And granted, I can't always get through to patients, but I do my best. And I think that that's what patients really want to know is that you have their best interests at heart. You respect their values and their intelligence, and you're trying to help them meet their goals.
Yeah, and that's the thing. At the end of the day, every doctor is going to approach. Not every doctor is going to get through to every patient. There's going to be preferences based on a variety of factors, many of which you cannot control. If you're an asshole, you can control that, but if you don't know you're an asshole, you can't control that. So that's a problem too.
Some patients respond better to that too. And if you talk to them like you're out having a beer, they might actually listen to you more. And, I try not to use ivory tower language, or sometimes what I'll do is I'll use the medical term for something and then I'll say, hey, let me translate that into English for you. And people tend to like that stuff too. And that actually does, I think, dovetail really well into the discussion on measles and all things surrounding that controversy.
And you also have people who are very educated, or at least book smart, educated. And so when I told a patient recently, I had a patient with a pretty bad asthma attack who later on I ended up admitting. And I told him, I said, okay, we're going to give you a few medications, albuterol is an inhaler. We're going to do a steroid. So I imagine we're going to give you magnesium. And his knee jerk response is, well, magnesium's not a medication, it's an element. We all have it. And he's not wrong. I said, you're correct. We all do have that, but we combine it with magnesium and sulfate and mix it into a liquid, and then it becomes more of a medication that we can give to you. Like respecting somebody's knowledge and intelligence to say, okay, you recognize magnesium is an element. So what exactly you're giving me here? We all have that. How's it going to help me to further now be able to define, well, this is how it's going to help you. And This is one thing I teach my residents, which is you got to know your medications that you're using. Because when a patient asks you about its details, if you can't answer it to some degree, I'm not saying you have to know every single bit of pharmacology, but if you can't answer why we're giving you common medications for common things, then that's a problem. And you are going to lose the trust of your patient, or they're going to let you do it because you're the doctor, but they're not going to like it. And that's going to reflect poorly on you more as an individual, less on the institution, or whatever the case is.
It's something I tell residents, it's something I call humble credibility. If you make it clear to your patients that you're aware of your limitations and you make those limitations clear, you don't want to do like, oh, hey, by the way, I am terrible at this, but I'm really good at this. You don't always have to phrase it that way. But what we can say is, I'll give you an example where if I'm making a decision to give someone an antibiotic for name your condition, right? And they'll say, is this going to cure me? What I'll say is this: what I'm doing right now is trying to cure you. Will this come back? Maybe. Can I guarantee success? No. I'm trying to give you the best possible chance of success here. I'll say what this will do, say it's cellulitis in a patient with chronic lower extremity
Yeah,
edema, right?
that's a common
Swollen
one, right?
leg, infection. What I'll say is it'll treat this current infection, but to reduce your risk of having this happen again, you need to take care of the core problem, and that's the swelling on the leg. That's taking your diuretic, your water pill, as some people call it. That's doing the leg elevation, doing your compression wraps once it's safe to do so, once the cellulitis is dealt with. And here are my limitations to trying to treat your condition, but what I'm doing right now will help you now. One of my things that when I have residents or trainees is, well, my first thing that I say is whenever you have a new patient, the two T's, check the teeth and toes. It'll tell you a lot about a patient and their current state of health. The other thing is it helps to give a shit. If you care about a patient, you don't just see them as a gown or something. It's exhausting physically, mentally, and time-wise to kinda to do that, but, you get better outcomes. But when you're trying to tell someone, I think our generation responds better to this too, is, "Here's the treatment I'm giving you, and here's why, based off of this information, and here are the limitations of it. And here are the areas that this treatment may fail. So I need you to partner with me to to let me know if you're experiencing this symptom, that symptom, or that symptom, because that'll tell me that this isn't working the way it's supposed to.
Right.
And then we'll
Yeah.
follow up. And then that way, one, they're forced to understand what we're doing and why. And two, again, it shows they're dealing with a human being that cares or, wants to
Or
make
at
them
least
better.
understands where they're coming from and understands
That's
their
a,
concerns.
that's a better way to put it. Yeah.
Right now, as of this recording anyway, measles have now hit a 30-year high. Measles cases have hit a 30-year high in the United States. We reached at least 1,000 cases in the US. And it's mostly among the unvaccinated communities. Obviously, Texas, pockets here and there in the Northeast, but it's spread from Texas out to the overlying states. And now we have to talk about vaccines to some capacity. We're going to have a separate discussion on vaccines later on, but you mentioned about limitations. And I think in the past 5 years, the limitations of vaccines have kind of been an underlying theme of the, shall we say, the anti vax argument, which is, well, I know so and so who got X disease and they got vaccinated. None of us in healthcare, none of us who are physicians look at that and are surprised by that. We look at them and say, yes, yeah, that's expected. We anticipate there being breakthrough infections even among vaccinated individuals, whether that be measles, whether that's whatever, rubella. Obviously, COVID and flu have been bigger discussions the past 5 years, but how you are infectious disease.
Mhm.
First of all, do you deal with a lot of vaccine preventable illnesses where you're at right now?
Well, I'm not in pediatrics, and I'll start with that. But as far as vaccine preventable illnesses, how many do I see? Not that many, to be honest. I did recently have a patient with a fresh heart transplant who got pertussis, and he thankfully did okay with treatment.
And
I don't.
pertussis being that whooping cough, right? That really like bad, like
Yep,
kind
yep,
of
yep.
coughing. I can't do it without actually hurting myself, but it's not a pleasant if you ever heard a child or even adult with that cough. It sounds painful, like incredibly painful.
Yep, it's easily vaccine preventable. People do die of it. This gentleman did okay, fortunately. But as far as vaccine preventable illnesses, I'll say that there's not a wide breadth of them that I'm dealing with consistently, but there's a large number of people with vaccine preventable illnesses that I deal with, mostly influenza and COVID. I see a lot of that. But To qualify it, talking about limitations, something that I do have to make very clear to people is that the influenza and COVID vaccinations aren't necessarily there to keep you from getting those illnesses or to keep you from dying of them and keep you
Yeah,
from being hospitalized.
and I think in 2020, 2021, you got the COVID vaccine, and it was the first time in a while that we had a vaccine that actually prevented illness. And people are equating it, at least in my circles, with the MMR shot, where you got the MMR shot, you didn't get the diseases. When you got the first doses of COVID vaccine, people did not get COVID, at least until the Omicron variant came out, when it became was a little bit more milder and changed so dramatically that the vaccine wasn't as effective. But even now, we're still seeing people who get the influenza and the COVID vaccines not being hospitalized with them. They're sick, but they're not so terribly sick where they need to be hospitalized. And we had a pretty bad flu season this past year. I don't know if you felt that out in Milwaukee and Wisconsin as well.
Yeah, I did. And that's a good point. Is early on, yes, it really did prevent illness, but just not anymore. And I think setting the expectation really, again, helps to bridge some gaps and has helped me to get people vaccinated. And then, I've heard people give reasons for not getting COVID shots. But one newer phenomenon, too, is people got the original series of the COVID shots, but they're not getting the booster. But some of the conspiracy theories are out there. I do try to address those as well.
What, as far as the measles go, so you obviously don't deal with pediatrics. We had a whole segment, a whole show on pediatric fevers. And I actually recently talked a bit about the RSV vaccine, where there's data that shows the RSV vaccine significantly reduced hospitalizations in infants and pediatrics with RSV. How do you approach the topic of vaccination now? Because you don't just work primarily, you see patients who are sick from other chronic diseases that are more at high risk from disease that can easily be more treatable and more managed with vaccination. You mentioned pertussis being one. How do you approach that conversation?
Well, and I will start with saying sometimes we do have to give these MMRs even to adults, especially people who are anticipated to be immunocompromised later, because then they won't be able to get live vaccines. So that's one area where we do see that. So, how do I approach the vaccination conversation? Well, I start by trying to see where the patient is at with it, see what vaccines they've already gotten. And that can help me to launch into the conversation of, well, what have you already gotten? What might you be willing to hear from me now? That's where I start. I try to figure out their life experience and what their hangups might be and address those in a respectful way.
What are the common hangups, shall we call them? What are the common issues that you've seen people have with the vaccine? It's not all autism, right? Like autism obviously is a big one out there. We're not going to address that here, but autism is obviously being one. Are there any others that you've seen?
A couple as well. Well, especially when people do ask me about vaccinating their children. Again, I don't do peds, but we need to have a really good backbone of understanding about how these things affect children and adults and what the risks of adults transmitting infection to children are, because a lot of people are exposed to children or children are exposed to them routinely. So a lot of the issues that I hear from people is, well, this is a lot of shots all at once. Am I going to feel terrible tomorrow? Or is this a lot for my immune system to take all at once? Or, hey, will this make me sick even temporarily with the illness you're trying to vaccinate against? So those are some of the things I hear. Then you get some of the fringe, like, oh, is there a microchip in this? Will it make me sterile? Will it make my arm blow up? Or one time I caught cellulitis in my leg after I got a shot in my arm. Therefore, that's what did it. Or, I do get legitimate questions about these things. Another one is Guillain-Barré. People ask about that too.
And that is a complication that people need to be made aware of. But also, we as doctors are aware of it as well, that is a possibility. Obviously, with COVID, we saw myocarditis as a side effect in younger people with the COVID vaccine. But the caveat to that is, well, COVID itself causes myocarditis, especially in younger people. So the incidence of when we say something like incident, where we talk about the number of cases with it, the incidence of a younger person getting myocarditis with COVID is a lot higher than the people getting myocarditis with the vaccine. And the myocarditis that get from the vaccine is oftentimes very, very short-lived, as opposed to somebody with COVID-19, they can wind up in the hospital, sometimes the ICU with myocarditis. And one other vaccine that we talk about with our patients but doesn't get enough press time is the shingles and the pneumonia vaccine. So that's obviously geared towards older adults, but the pneumonia vaccine doesn't treat or prevent all pneumonia. It prevents a certain strain of pneumonia. Can you talk about that a little bit?
Yes, I will. But first, I'll say, yeah, with the something I say that a lot of some of the side effects of the COVID vaccine, you'll get all those things, but worse with COVID itself. But with the myocarditis point, you're usually not only sick with myocarditis when you have COVID, but also the respiratory failure. So there's that, and then long COVID and
Yeah.
all that. But that's
Yeah.
another discussion. So the pneumonia and shingles shots, and I'll also take that a step further for the meningitis ones, Menveo
Mm.
for, you
Yeah.
know,
Hmm.
ACYW, and then for the B strains. They call it the pneumonia vaccine because you're vaccinating against the most common pathogen that causes pneumonia, Streptococcus pneumonia. So, but what people also don't realize is Streptococcus pneumonia across the board is also the most common pathogen that causes meningitis as well. So I do talk to patients about that as well, that it doesn't prevent all types, but why not give yourself a vaccine that will significantly reduce your risk of getting pneumonia from the most common pathogen? And the way that it is with the newest vaccinations, the courses are shorter than they were, and the side effect profile is better, and the immunogenicity is really, really good too. So, the way I talk about it with patients is that when you get to these ages or demographics or risk factors to get pneumonia, your risk of a fatal outcome with pneumonia is so much higher. And that's why you want this vaccine, because it's going to reduce your risk of getting really sick or even dying.
So measles can cause something called encephalopathy. It's not meningitis per se, but it can cause complications like encephalopathy. What is encephalopathy, first of all, and is it deadly? Is that what kills people? Is it like something else from the measles that kills people? How does that work?
So, encephalopathy being altered mental status, that's more of a side effect or a downstream effect of encephalitis, which is the rare but serious effect of having the measles. So that's an extreme example. And that does happen enough that that's a problem. The most common problems with measles, really, you're going to start with the most recognizable, I'll say, is the rash, which is pretty common, right? You get conjunctivitis, you get coughs, you can get pretty sick with it. And I'll talk about the things that really concern people. How often are people hospitalized with the measles? You hear people say measles isn't a big problem. And then I'll circle back to that question. There was data out fairly recently that something like 10 to 15% of people require hospitalization due to illness of measles, mainly kids. And that really does depend on your age group. And this is really something that impacts children more. There was some data that showed something like 20%, 25%, and I'm sorry it's not an exact number, of kids under 5 require hospitalization for various issues. Not
Emergency
only
medicine, we don't worry about exact numbers anyway. It's fine. Don't worry
right,
about
so
it.
not only is
I pull numbers out of my ass all day long. It's fine.
that's fair. So not only is it the encephalitis, but I'll get to the more common one. Pneumonia is a problem. That's a problem, especially in kids with weakened immune systems. And then when you get up to like 5 to 20, it's like 10% of hospitalization or down to 10%. And then when you're over 20, it's usually somewhere closer to 5 to 10%, maybe 7% is something I read. But pneumonia is a common complication in kids. Encephalitis, I'll get to that now. That's only something like 1 in 1,000 cases, but it is serious. Subacute sclerosing panencephalitis. If it sounds bad, it's because it is bad.
The longer the Latin name, it's usually worse than it's usually pretty bad.
What is it Conrad Fisher said? The difference between the English word and the medical word is the cost of tuition. And so what it is it's brain inflammation. It's panencephalitis, pan being not a kitchen utensil. It's everything. You get encephalitis, which literally means inflammation of the whole brain. And sclerosing means it hardens, it gets scar tissue. If that's horrible, that's something that can kill people, right? And so, was it something like 3 confirmed deaths of measles as of last time I looked in the United States? And it's a horrible way to go. Your brain is getting inflamed, or your lungs can't get air. So, when you die of measles, it is a bad, bad death. One thing that people don't appreciate is, American hero Lou Gehrig. He was one of 3 kids. 2 of them died of vaccine preventable illnesses now. They weren't vaccine preventable then. One of them died of the measles. One of his siblings died of the measles.
Yeah, and that's one of the reasons why, the MMR shot is recommended for those born after a certain year, just because it was so prevalent, decades ago that it was thought that, well, you don't need the measles if you're over this age because you probably already had it. It was so prevalent. Yes, we've seen childhood mortality drop significantly since these vaccines were introduced, specifically the MMR vaccine, because these kids were dying from measles and rubella and pertussis and all these terrible diseases. Think uh, I think the average life expectancy has increased not because people are living to older and older ages, but because the amount of children dying has decreased so much that the average age of the person has just increased dramatically, even over the past 60 years.
Right, that's true. I was reading a statistic that I believe in the year 1800, the average child had about a 60% chance of living past age 5. Was it 40 to
Now, we
60%? Terrible.
Yeah, and that's also why people decades ago had more and more children. You started marriage was at a younger age, and as soon as you were married, you had kids because there's a good chance that of the 4 or 5 kids you had, two would probably die before they reach the age of 5 or something like that.
Right.
Um,
Again, Lou Gehrig was one of only 3 to survive childhood, and Abraham Lincoln had already lost a child before he even left Illinois for the presidency.
that's
It's
right.
the truth.
That's right.
But, getting back to measles, you brought up an interesting point, and we also discussed about vaccines preventing illness and how I discussed how a lot of the ones like COVID and the flu no longer are really expected to prevent illness. They're there to prevent you from dying. As you mentioned, the measles vaccine is an interesting one because it does prevent illness, but then herd immunity is the other thing that really prevents illness. If nobody's getting the illness, no one's going to get it. Whereas the measles vaccine MMR is very effective anyway. You have over 90% effectiveness, even from one dose, of preventing that when you're exposed. Say someone with the measles is around you and you've got even one dose, you have over 93% prevention rate. 2 doses is 97%.
And that's important to know for parents with children because the second dose of the MMR vaccine is not given until the age of 5, 4. I want to say, I have to look that up. I believe the second dose of the MMR vaccine is not given until basically the kid goes to school, preschool, kindergarten. So the first dose is given when they're 1 year old, when they hit their 12-month birthday. And so in the interim, though, you're thinking, well, gee whiz, how effective is one dose of this vaccine? Pretty goddamn effective, believe it or not. And there's always concern with the measles outbreak, like how do I protect my child who's 19 months? And the answer is if they've been vaccinated, they're already pretty well protected. But it's how do I protect my child if they're 6 months? The answer is herd immunity. It's the idea that if you've been vaccinated, if you're around other people who've been vaccinated, the ability of the virus to get to your child is significantly hindered already. But and this is another question I have for you is how contagious is measles?
Very,
Very, yeah.
very.
The answer is
That's
going to be
the
very.
other. The way I was going to express that is it's the type of isolation you put someone in who is sick with it, right? One of the few that's airborne. So in the hospital, everyone's wearing an N95 near the patient. It's very, very transmissible.
How transmissible is it? Are we talking like if I'm sitting next to you in a subway car for 5 minutes, am I going to get measles just from sitting next to you like that?
It depends on, am I coughing? Am I aerosolizing these things, you know? And also the part of it too is you don't always have to be. One of the benchmarks we use is are people showing symptoms, right? So the contagious period really for this virus, about 4 days before the rash appears and about maybe 4 days after the rash goes away, you can still be contagious. You can really spread it again through airborne transmission, coughing, sneezing, direct contact with an infected person's respiratory. So if we're sitting next to the train, and you kiss me, you're going to get the measles. Or even if you touch
I don't know
something
you that
like,
well, Kenny. That's fine though.
we go way back, but not that far back. Or if, I hadn't washed my hands after I sneezed and we shake hands, touch your face, you're going to get it.
And
But
let's say that somebody's in a restaurant and they're coughing and they were diagnosed with the measles and you come in after them. They're no longer there and you come in after them. Can you potentially get it?
I don't know the exact time, but if it's still hanging in the air, you can. I mean, it's so infectious that if someone's unvaccinated, it's something like 90% of unvaccinated people who come into contact with someone are going to get the measles. And it also, keep in mind too, it's got over a 75% secondary attack rate.
What does that mean?
So, if you get it and there's other people who are household contacts, someone who gets it is going to transmit it a lot more frequently.
Okay. So
And
if
without getting too academic, to explain what exactly that is, because I'm getting a little bit too much into my
your
into
your
my
research roots
ID
here,
group. But it's like if 10 people, let me give a better example here. It's basically, what it basically measures is how many, and to keep it in English, it's how many people become infected with the disease after being exposed to somebody with it, right? So if 10 people live with someone who has measles and 8 of them get measles, that's an 80% secondary attack rate.
Okay.
Is
That
that a
makes
good
sense.
explanation?
That makes sense. Yeah. Yeah. I like whole numbers. I like decimals. I'm terrible at math. So whole numbers like 100, 10. Perfect. I like it.
Sure.
Is there a treatment for measles? You get an adult now who comes in who's hospitalized with measles for whatever reason. They get pneumonia. Obviously, you can maybe treat the pneumonia. Maybe, I don't know. Actually, can you treat the pneumonia complicated by measles? Is it a bacterial pneumonia or is it a viral pneumonia?
So, direct treatment, there has been some talk of vitamin A being helpful. But really, prevention is the main thing. There is post exposure prophylaxis, which you can do. Some people, before I don't want to get too much into details on that, but there is a window of exposure when you can get vaccinated and also get intravenous immune globulin if you have to. But then,
For
as far
those
as
states, so for those who have not been vaccinated or who have been vaccinated but exposed, who is that useful for?
non-vaccinated, and especially with the individual immune status compromised, that's the main one. But as far as treatment goes, vitamin A is something people have talked about, but where I will see it, if I do, is mostly when I'm treating people for secondary bacterial infections.
Okay, so vitamin A. Let's talk about that a little bit. Um, you're obviously infectious disease. You don't deal with toxicology in any capacity. Vitamin A is a common vitamin that's found in many different foods. People take it as a supplement. It can help with uh, vision. I understand it to be, some people say that, oh, take vitamin A or K, improve your eyesight, whatever. But vitamin A is part of a family of vitamins, A, D, E, and K, which are fat soluble, meaning they're stored, you intake them via whatever means, supplements, food, and it's stored in your liver. And when it gets low, your liver releases it to keep a steady supply there. Not everybody is deficient, though, in vitamin A, right? So now you have a situation where somebody comes in who overdoses on vitamin A, and you're seeing encephalopathy, encephalitis, not from the measles, but from vitamin A overdose, complications with liver disease, liver failure, things like that. So if you get somebody who comes in with the measles, you, your hospital, your clinic, whatever, have a protocol that says we need to give this person vitamin A, or no? What?
Most of the
Yeah.
time when people get to me with measles, it's because they have a secondary pneumonia.
But that's good to know. So people come, by the time you see these patients, they've already had a secondary infection, and you're more focused on treating the secondary infection, not the primary source, largely because there's no treatment for the primary source, right?
Correct? And that's where things really, really shit hits the fan.
By the time they have a secondary infection, a secondary complication, can you give any semblance of a number, a ballpark number of survivability?
I don't have a ballpark number, even a broad one, because frankly, yet we're not seeing enough of the measles in adults yet to give a good answer on that. Really more of
So that's
my
a good thing.
right so far, where I see more of that is with influenza and COVID. And when people get those, back during the Delta wave, the survivability was very bad, because not only were we seeing people with severe COVID, but they were also sometimes needing some pretty significant immunosuppression, high steroids, or example, or anti-IL-6 treatments, as you know. And then people's immune systems would be way down, and we would have to prophylax against pneumocystis. But when people were getting secondary bacterial pneumonias, that was pretty bad. They were sick enough already to get that, but was also seeing a lot of secondary fungal pneumonia too, with aspergillus or even mucormycosis. The
And those are
survivability there was really tough.
And those are terms you don't hear every day, right? Like mucormycosis, aspergillus, you're like, holy shit, what are those things? Those are very rare infections for a reason. They only affect a very small percentage of population, mostly those who are immunocompromised for one reason or another, which is why it's always important that if you know you're going to be immunocompromised for any reason, organ transplants, even like undergoing surgery or like high dose steroid usage for your asthmatics is some form of immunocompromisation. Even like diabetes can sometimes be immunocompromised because you're not getting the blood flow to certain organs. Your body is highly, highly inflamed from just persistently elevated glucose levels. Like that's also a sort of immunocompromise that people disregard to some capacity.
That's true. That's very true. And those are tragic things that when you see them, by the time you get that sick, you can't always solve the problem, even though you want to. And you can try your best.
And prevention, it's funny that you have infectious disease talking about prevention because many people think of infectious disease as outbreak. The movie Outbreak, right, from the late 1990s, or even the movie Contagion in the early 2010s, they think infectious disease as finding patient zero and developing like the cure, right? But really, I think a big takeaway from our talk today is prevention really is worth a pound of cure. Like an ounce of prevention is really worth a pound of cure.
But that's the truth. That's the absolute truth. And that's really where the value lies. Once the horses are out of the barn, it's hard to get them back in sometimes.
All right. Well, that wraps it up for this episode. Dr. Kenneth Swanson. Kenny, thank you so much for being on the show. Infectious disease is a very broad topic. I know we touched on vaccines. We talked about measles, COVID, a little bit of flu. I think as the next flu season gears up, I want to have you back on here to at least talk about influenza and talk about some other stuff that's out there too. I think we had some good information presented here today, but we can definitely do more of a deeper dive into some other topics too.
I'd be happy to talk about that and come on again. That'd be great. And you did touch also on HIV. I think that would be a good one to discuss too.
Yes.
And that would also piggyback really well too on, talking about patients and the lack of othering and talking about destigmatization of certain things.
Yeah, I think all those topics we need to address more of, both just between you and I, but also in the healthcare in general. We need to do a better job of communicating these things. So again, Dr. Kenneth Swanson, one of my personal best friends, infectious disease, stellar physician doing the dirty work out there in Milwaukee, Wisconsin. Thank you again so much for being on here. I really appreciate it.
I'm happy to. Thanks so much for having me on.
All right, that wraps up another episode of the JAFERD Cast. Thanks again to Dr. Kenneth Swanson for joining me here to discuss vaccines, measles, infectious disease, what we can and cannot really do as a physician, and just tips overall about healthcare in general. It was a heavy episode and some political undertones as well, but hopefully next time we'll have him back on here, talk about other topics related to infectious disease, namely STIs, maybe some other stuff as well. We'll see. If you enjoyed this episode, please don't forget to like and subscribe and turn on notification. I love constructive feedback, and ultimately, this show is designed to help you, the listener or viewer, make informed choices about your own health and to raise awareness about the issues facing healthcare at large. You can leave your thoughts in the comment section below for those who are watching on YouTube, or email them to me at jefferdcast@gmail.com. If you're in the healthcare field and interested in being on the show to discuss topics in healthcare, please feel free to reach out as well. If you are a listener who wants to actually hear about a particular topic, please feel free to email them and I'll do my best to cover it, try and get the appropriate specialist on, or I'll just ramble on to the void myself and see what happens. As with anything, don't take my word for it. Do your own research, talk to your own doctor, and remember, at the end of the day, I'm just another fucking ER doctor. Make good choices, everybody. We'll see you next time.